So we're gonna start in a minute or so, but let me just start the recording here.
Shall we start, Dr. Nadir?
Yeah. Welcome to our Zoom meeting. Assalamu alaikum, everyone. And today we will have a couple of topics. Dr. Melas and her team will be presenting, and it's up to you, Dr. Melas, when you are ready, and your team, please take it from here. Thank you.
Thank you so much, Dr. Nadir. Good evening, everyone. I'm very happy to welcome you all to tonight's session of Geriatric Research Fellowship. My name is Dr. Malaz, and I have the pleasure of being your moderator for tonight's meeting. First of all, I would like to sincerely thank Dr. Nadir for giving us this great opportunity to be part of this fellowship and for his continuous guidance, support, and encouragement. We truly appreciate the time and effort he always gives to guide us, discuss our ideas, and help us grow academically, clinically, and professionally. I would like to also warmly welcome our new fellows who have recently joined the program. We are really happy to have you with us. Please feel that this is your space to learn, ask questions, share ideas, and grow step by step. No one starts as an expert, and the most important things are commitment, curiosity, teamwork, and the willingness to learn. And tonight we have a very interesting and diverse agenda. We will start with clinical. Let me first share the screen. Tonight we have a very interesting and diverse agenda. We will start with clinical topic about prostate disease, then move to an important and current topic on how to limit AI hallucination. After that, we will discuss how to become a health professional educationist. And finally, we will close with practical advice and tips for a start of residency. At the end of presentation, we will also open the floor for any shared ideas, suggestions, discussions, or project updates from the team. So tonight's meeting brings together clinical knowledge, technology awareness, medical education, career development, and research collaboration, which really reflects the spirit of this fellowship. Once again, welcome everyone, and a special thanks to Dr. Nadir for his presence, support, and guidance. Now let us begin with our first presentation. Our first presentation is about prostate disease, presented by Dr. Mison. This is an important clinical topic, especially because prostate-related conditions are common and can significantly affect patients' quality of life, particularly among elder adults. Since our fellowship has geriatric and patient-centered care focus, this topic is very relevant to our learning. Dr. Mison, thank you for preparing this presentation. So the floor is yours now. So you are welcome to start.
Thank you,
And if
Dr.
you
Malaz.
need any help, so let me.
Okay. Thank you, Dr. Malaz, for your presentation. Let me share my screen. Okay. Okay. It's clear? My screen showed?
Yes.
Hello?
Yes. Yes, it's
Okay.
clear, but can you make it like share at full screen?
Okay.
Click to the slideshow. Yeah.
Okay.
Then go ahead.
Okay. New slide. Okay. Okay.
Yes. Click to start from first slide, I think. Can you click it?
Slideshow setting.
First one. Isn't work?
No, doesn't
I think
work.
it's okay. You can start like that. I don't think there is I think it's big enough to
Okay,
be
thank you so
read. Yeah.
much. Okay. So today our presentation about prostate disease, especially in geriatric patient. So we will learn about US burden, benign disease, malignancy, and geriatric decision making. Want to go to next slide? Just 1 minute. How can I move to next slide?
You can use your in your keyboard.
Okay.
There is arrows. Yeah. Okay.
Yeah, I pressed in the arrow.
It's not on
Not
the right
moving.
side. All the right way to the
I
right
click
side.
in the right mouse. Yes, I click in the arrow. Just 1 minute. Okay, I will fix it.
No, on your screen on the right side, the farther on the right side, all the way in the middle of the screen, all the way. No, not the slide. You see the on the right side of the screen, the whole window.
Right side of the screen. Okay, where?
Whole window. Go all the way to the line. All the way to to your right.
Here. Right. Okay. Here.
All the way.
Here.
All the way. No, not the icons. Yeah, you are on top of the icons. Forget
Okay.
about that.
Okay.
Go all the way
Here.
to the
Okay, because
right
it's
side.
okay. Okay. Where?
And then go down. Go all the way to the right
Okay.
and then go down.
Okay. Here.
Click on the small. No, just me.
Okay.
Click on the small.
Okay.
Yeah. Is
Okay.
it?
Okay.
No. It
Okay.
doesn't.
Okay. Maybe this one. Let me show. Okay, not this one. Okay. This one.
I think you can click on the slideshow now. Slideshow up.
Slideshow. Slideshow
on the
here.
menu.
Yes,
Yeah.
here, right?
Yeah.
Okay.
Yeah. And then from current. Yes. No, it's not coming.
Okay. Okay. Can I do my presentation, the second one, to fix it this one?
You can, and even so, you can share with me the link so I can help you. So,
okay.
Dr. Amber, are you here? We can start with you, and then we can pass to Dr. Mison if you are ready.
Hello, can you hear me?
Yes,
Yes.
we can hear you well.
Yeah, it says that my topic is AI hallucination, even though it was supposed to be about systematic review. I don't remember doing one about AI hallucination or accepting to do something like that. It was supposed to be about systematic review.
Yeah, it's about how to limit AI hallucination.
Yeah, that's not my topic.
Which one your topic?
Go ahead if you have a topic ready.
Yeah, it was supposed to be a systematic review. It's just a quick how to do a systematic review.
If you want to start that would be great if you have it.
Can I just a few minutes, please? Because I wasn't expecting to be first.
Oh, no worries. Take your time then.
Thank you.
And Dr. Mison can share the link or the, yeah, you can just click
Okay.
on the
If
slide.
Dr. Mohammed need more time, I fix it.
Okay, perfect. You can start then.
Okay.
Thank you.
Okay. So did you see my screen now?
Yes.
Okay. Okay. Did you see, right? Okay. So so we will talk. Let's do from this one. Yes, it's working. Thank you so much. Sorry for the interruption because this is first time. Okay, so we will talk about the prostate disease in geriatric patient, U.S. burden, benign prostate disease, malignancy, geriatric decision making. After this presentation, we have to know a little bit about quantify the clinical and economic burden of prostate disease in USA in men, differentiate benign prostate disorder from malignant disease and urgent complications. We can also learn about the apply practical diagnostic approach to lower urinary tract symptoms, urine retention, prostatitis, and prostatic symptoms, and elevated PSA. Individualized management using virality and life expectancy, polypharmacy, anticoagulation because of pre-surgery, and goals of care. So, okay, I need to move this one. Okay. Why prostate disease matter in the geriatric medicine? Because of the aging of prostate and associated with comorbidity can lead to symptoms of lower urinary tract symptoms, pain, and high BCA. Can lead to also complication like acute urinary retention, UTI, acute kidney injury, and cancer. The clinical decision and screening are treated refer. So all these experience need to can lead to burden for the economy and the patient too. So the patient can complaining of from functional burden because have to get up at night because of nectaruria, sleep deprivation. Also, the urgency can lead home to risk for falls risk. Catheter can lead to infection and distress. Also, we has a medical burden. UTI can lead to sepsis and delirium, urinary retention, and obstructive uropathy, acute kidney injury. Also, the cancer burden, the common malignancy, indolent versus aggressive disease, also the high stake of the staging. The treatment burden, because of the treatment, have also side effect. The alpha blocker can lead to orthostasis and fall risk. Anticoagulation can lead to cognition effect and constipation, and incontinence and sexual effect. Okay, the epidemiology and morbidity burden in USA. This paragraph can show us how the burden signals in the older men in the clinical BBH more than 65 is 31%. And chronic pain and chronic prostatitis, chronic pain syndrome in US men is 12%. Acute urine retention in patient more than 70 in 5-year risk is 10%. And acute urine retention and 5-year risk in older 80s is 33%. And also prostate cancer cases more than 70 years is 43%. So the new cases in US prostate cancer case reported in 2022 is 255,000 cases. Also adjusted incidence case in the men in US in 119 per 100,000 K in US. Also, the US reported in 2023, the US death is 33,000 case. Also, 2 million annual US visit for prostatitis. The morbidity is driven by obstruction, infection, inflammation, catheterization, treatment toxicity, and advanced cancer, not only mortality. So here the economic burden because of chronic care, also the procedure surgery and the cancer supervisorship. So the most cost driver is from repeated visit. They need urine analysis, culture, PCA, and also follow-up imaging and cystoscopy. Also, in chronic medication because alpha-1, they need alpha-1 blockers, 5-alpha alpha reductase inhibitor, antimuscarinic, B3 agonist. The procedure total urethral resection, prostatitis, holmium laser, prostate lift, water valve terminal therapy, and BAE, even simple prostatectomy. The cancer care also need biopsy, MRI, PSMA, PET scan, is prostate specific membrane antigen, radiation, need surgery, androgenic deprivation therapy, systemic therapy. Also the indication burden, catheter care, caregiver, falls, hospitalization, and financial toxicity. So this paragraph show how cost the effect only of all the treatment of prostate. So the BPH private sector annual, they spend $4 billion per year in, I think in the year, specific year, they didn't mention it. Okay. In the BPH surgery, mean added 5-year cost per patient is $20 million per patient. Prostate cancer national care in 2020 is spent $22 billion. Also, all cancer national care in 22, they spent $208 billion. So all of this is economic burden because of the prostate disease. So here the figure, they showed that anatomy and age-related prostate changes. The prostate is surrounded the urethra at the bladder neck here. That this is the transitional urethra, transitional zone, sorry. Here the transitional zone is a typical origin of BPH and the bladder outlet obstruction. So here the prostate, when enlarged, close the neck of the bladder, they make it the BPH sinus symptoms. Peripheral zone here, the common origin of prostate adenocarcinoma. Prostate enlargement can trigger the trousal overactivity, retention, UTI, stones, hematuria, adrenal dysfunction. This is a transurethral. Here the catheter can send the thermal chemotherapy like microwave therapy, so they make shrink this prostate and they can relieve this obstruction by relieve this enlargement tissue. Age-related biology. The androgen is the most common cause, the androgen signal that cause the prostate more enlarged, dihydrotestosterone, stromal epithelial growth, smooth muscle tone, inflammation, and the bladder remodeling interact with comorbidity and medication. So here the table can summarize all the classification of prostate disease in men. We will start with the benign growth obstruction. Benign growth obstruction, as we said in the previous picture, can cause to BPH, benign prostatic enlargement, and a bladder outlet obstruction and the sign of symptoms of urinary tract symptoms. The patient came with nectaruria, complaining of nectaruria, urgency, weak stream, hesitancy, incomplete emptying. So we have not missed about acute urine retention or recurrent UTI, and also they have a risk for hydronephrosis and acute kidney injury. The patient also may come with inflammation and infection. So acute bacterial prostatitis, sometimes a chronic bacterial prostatitis, and another cause is a chronic prostatitis with the chronic pain pelvic syndrome. Is not bacterial, but it's inflammation. The patient came with dysuria, pelvic perineal pain, fever, recurrent UTI, pain with ejaculation. Also, we don't have to miss the sepsis because risk of infection, and avoid prostate massage in acute prostatitis. Acute retention. The patient with acute retention sometimes due to two causes, sometimes spontaneously or precipitated by medication like anticholinergic drug, and also constipation can lead to acute retention, and anesthesia drug also weak the dorsal muscle to contract, increase the risk of acute retention. So how the patient came: painful, inability to avoid, suprapubic distension, delirium, may be presenting sign. Also, in acute retention can lead to risk of acute kidney injury. Post-operative diuresis is the complication after relieving of acute retention, that loss of a lot of urine in 24 hours to 48 hours that may lead to electrolyte imbalance, and catheter trauma. Less common benign, sometimes patient came with the abscess, calculi in the prostate, hematuria, post-procedures complication. How patient came: persistent fever, refractory UTI not improved with antibiotic, pelvic pain, and hematuria. We have not forget a patient about diabetes and immune-compromised patient, high risk for abscess, and image atypical cases. Malignant case, the patient, the type of prostate adenocarcinoma, advanced metastatic disease, the patient awfully asymptomatic and elevated BCA, abnormal digital rectal exam, bone pain, and or weight loss if advanced, high grade metastatic cancer even in older adult. Okay. We will talk more details about BPH and lower urinary tract symptoms. The aging with androgen is the first risk factor for BPH, can lead to dehydrotestosterone, or lead to stromal epithelial growth, so lead to transitional zone enlargement and bladder outlet obstruction. So this lead to lower urinary tract symptoms and complication. The risk factor, the age, I corrected this one, is more than 50, not 40, little bit the patient with less than 40. More than 50, strong age gradient with a family history, the obesity and sedentary lifestyle, also risk factor, diabetes and cardiovascular disease, CKD, and erectile dysfunction associations. Symptoms, the patient came, as we said, voiding, weak stream, hesitancy, straining, intermittency, and the storage, because the bladder cannot tolerate a lot of urine, so he has complaining of frequency, urgency, and nectaruria. Post-maturation, dribbling, and incomplete emptying. Complication, the patient came with acute urinary retention, recurrent UTI, prostatitis, bladder stone, hematuria, sometimes hydronephrosis, and acute kidney injury and renal insufficiency, also risk for fall and sleep deprivation from nectaruria. BPH and lower urinary tract symptoms, diagnosis and management. So the older man with the sign of LUTS, we have first initially evaluation. We have in evaluation international prostate screening score, digital rectal exam, UA urine analysis, post-voiding residual volume, and with BS if the change the management, because the treatment sometimes can make the BSA increase or decrease. They change the BSA. The risk stratify. So we have to know this patient in high category risk patient or moderate or mild. Mild versus moderate severe or complication, or he have a red flags risk factor. Treat the patient and reassess him after 4 to 12 weeks for medical therapy. If the patient have any complication or red flag, so we have to refer him. The patient with mild to moderate and mild, non-bothersome. So just follow up, and we can start with conservative management, like advise him not to drink a lot of water in evening before bedtime, reduce caffeine and alcohol because this is diuretic, and treat constipation if there's any constipation. Some patient with mild can improve. If the patient not improve in the conservative management, now we can start medical therapy like alpha-1 blocker, add 5-alpha reductase inhibitor if the enlarged prostate, and storage agent continuously. If the patient not improve in the treatment, we can start procedure or surgery, transurethral resection prostate, holmium laser, prostate lift, urethral lift, or water vibration terminal therapy. This is shrink the ureter, and BAE, simple prostatectomy depending on anatomy and goals of the patient. So here the geriatric patient caution: the patient in old age, they have high risk and susceptibility to the orthostatic hypotension, falls due to alpha blocker, and cognition and constipation due to anticholinergic medication. And we have to focus in pre-procedure anticoagulation and fertility planning. Prostatitis in older men. National Institutional Health categorized the prostatitis in 4 categories: acute bacterial prostatitis and chronic bacterial prostatitis. We have also chronic prostatitis, chronic pelvic pain syndrome. This is chronic prostatitis not related to bacteria. And we have asymptomatic inflammatory prostatitis. The older patient risk factor, BPH and urinastasis. So good media for bacteria, recent catheterization and cystoscopy, biopsy, recurrent UTI, also the patient with diabetes and immune-compromised patient, ureteral strictures of instrumentation. Clinical distinctions: acute bacterial patient also came with a fever, chills, toxins, toxic appearance, dysuria, and tender in prostate. If we take a culture, and we have to take culture and urine analysis and start antibiotic. Patient with a chronic pelvic pain syndrome is a pelvic pain syndrome more than 3 months, awfully non-bacterial, the culture is negative, and also BSA awfully normal, and is a disease diagnosis by exclusion, and the treatment by alpha hydroxylase therapy. Okay, sorry. So also we don't forget about urgent red flag if acute bacterial prostatitis with a sepsis and urine retention. This patient need more level hospital level evaluation. Management principle: obtain urine analysis, all patient, and urine culture before antibiotic proceed. Avoid prostate massage in acute bacterial prostatitis. Treat bacterial prostatitis with a culture, direct therapy, and evaluate obstruction. CPPS often need alpha blocker trial, anti-inflammatory strategy, pelvic floor therapy, and psychological assessment and pain focus care, because this patient complaining more than 3 months of pain and go through all the symptoms. Acute urinary retention, less common prostate condition. So this paragraph show how acute urinary retention per 1,000 person. So if the patient mild lower tract symptoms between age 70 to 83, he come with the presentation 7.9%, but patient with the same age, moderate with severe came is 11% with acute urine retention, and the clinical BPH plus acute urine retention score more than 90 is 13%. So immediate approach of acute urine retention: confirm retention clinically or by bladder scan, of course, abdominal ultrasound or pelvic ultrasound. bladder decompression with Foley catheter, check creatinine, urine analysis, and culture when identify participating infection, if there's constipation, or he take medication, anticholinergic, sympathomimetic drug, anesthesia, and urological lesion. Plan trial without catheter plus alpha blocker when appropriate. Less common but is important. We have prostatic abscess, especially in patients with diabetes and immune suppression, persistent fever despite antibiotic. Also, there is a case of prostatic calculi. We don't have to forget recurrent infection and pain. Post-procedure complication, patient complaining of hematuria, infection, and stricture incidents. Also, red flag, all the symptoms need more level for hospitalization and evaluation. Here we will talk about prostate cancer, epidemiology and risk factor, and screening controversy. This paragraph we will show us prostate cancer common and is a common but is a usually survivable and but still lethal. So here in this paragraph in 2026 we recorded new cases 333,000 in new case, but the lethal death cases is 36,000. Age distribution, U.S. prostate cancer diagnosis in 2026 between age 45 to 54 is only 5%, so it's very low. More than 55 to 65 is the most common incidence is 52%, and more than 70 is 43%. That's why they not indicate to do BCA for more who than older than 70 years old. So the risk factor of the prostate cancer: age, strongest risk factor, non-Hispanic, plaque race, highest incidence and mortality, family history, germline variant, including BRCA1, BRCA2, Lesion syndrome gene, and BOXP13. Obesity may related more to the aggressive fetal disease than overall incidence. Smoking and cardiometabolic health effect, treatment tolerance, and combating mortality. Screening. So here is U.S. preventive screening task force. So when we have to do the screening of BCA, individual BCA decision aging between 55 to 69 is recommended against routine BCA screening for more than 70 years old. This is American Urology Association and Society Urological Oncology share decision-making individual by the risk of the life and expectancy. So it's dependent on the patient if he have a chance to have a long half-life or a short half-life to do the screening test. Geriatric principle, screening only when the detection would lead to beneficial action. Yes. So this prostate cancer diagnosis, staging, and management in geriatric. This paragraph show us when the diagnosis of the prostate cancer, 70% they showed is just localized in prostate. 7% is unknown, 9% is distant, and 14% is regional. The patient who localized in the region, 99% is survival. All stages is still highly survival rate, 98% survival. Only distant is 37% survival. This is the picture of adenocarcinoma of the prostate. So how we diagnose the prostate cancer? Repeat, confirmed by BCA. Also the digital rectal exam, you can feel the hard nodule, fixed, not mobile, irregular margin, risk calculators, reflex biomarker when appropriate. Also, this is membrane prostate antigen MRI, like PET scan, targeted and increase the systemic biopsy and the grade of a group and risk category. Staging tool. we have to know if this is still localized or staging. For unfavorable intermittent high-risk disease, we can do pelvic MRI, CT scan, bone scan, prostate antigen membrane, PET scan where available, and symptoms directed evaluation of bone pain or neurological compromise. The treatment is option and also dependent on the stage and the patient, how long life he will be. So active surveillance, watchful waiting, radical prostatectomy if localized, also with radiation, and anti-androgenic therapy or androgenic deprivation therapy, also androgenic deprivation therapy along with selected non-curative goals. Also sometimes the patient needs a systemic treatment if metastatic disease. So here the geriatric specific decision making, assess the fitness and virality of cognition, how the patient affected in his daily life activity, how he's fall from the treatment, estimate the benefit and the window of life expectancy and disease risk, identify the treatment hazard, medication and the side effect of anticoagulation, and because the treatment of the pre-surgery and anesthesia, and the shared decision patient goal and the treat of the side effect and positive and negative, and he will decide what he wants. So the medication alpha blocker, because alpha block, so will lead to alpha vasodilation. Patient will complain from orthostasis and syncope and fall, and this is very high risk for geriatric patient. 5-alpha reductase inhibitor side effect, sexual adverse effect, and also change in BCA interpretation. Anticholinergic can lead to constipation and urine retention and lead to cognition, sometimes to delirium. Diuretic like SGLT2 inhibitor, patient, because it's diuretic, patient came with complaining from nocturia and volume effect. Procedure issue, anticoagulation, antiplatelet planning, this is through the surgery. Post-op delirium and catheter tolerance, sometimes patient baseline continence and sexual functional. We have to make sure his life is dealing with a normal daily life. Sometimes need to transportation, caregiver support, rehab after the surgery, and assess if he have a risk of infection risk. Cancer issue, avoid screening and treated when the benefit window is short. Yes, no need if the patient very long, short half-life. Do not under treated fit older patient with aggressive disease. Use active surveillance for low-risk cancer when appropriate. Follow up if reasonable when the palliation is a goal. So this is the pictures. I think is the last slide. This will summarize all the what we're talking about BPH, prostatitis, and cancer. So here the older men came with lower urinary tract symptoms, retention, and pain. So and the BCA sometimes is high. So we have to initial triage. If there's any fever, retention, or AKI, hematuria, or neuroscience. Also, we have to do basic workup, urine analysis, culture, medication, digital rectal exam, post-volume residual volume, and creatinine. And focus in pathway if BPH or prostatitis or acute urinary retention or cancer risk. So if the patient mostly his symptoms with lower urinary tract symptoms, so by the score, just lifestyle modification, sometimes need simple medication, sometimes refer to urology if complicated or refractory. If the patient have noticed that complaining of infection or pain, so treated with culture-based antibiotic, treated bacterial disease, avoid reflexive disease for CB and CBBS. If the patient BCA high and cancer concern, so we have to confirm it by BCA, assess the risk and lifestyle, life have long expectancy, MRI for biopsy and action likely. So 5 takeaway. BPH, lower urinary tract symptoms, is a common, but some symptoms are not always prostate derived. Retention, sepsis, acute kidney injury, hematuria, and neurological signs require urgent evaluation. Prostatitis is not synonymous with chronic bacterial infection. BCS screening in geriatric should be individualized by life expectancy and goals. The safety plan is the one aligned with the disease risk and geriatric vulnerability. Thank you so much for listening to the presentation.
Thank you. Thank you so much, Dr. Mison, for this informative presentation. It was a very useful clinical topic, and we really appreciate your efforts.
Thank you.
So, if anyone have any question or want to add anything, Dr. Nadir, if you want to add any point or idea, if anyone want to ask, you can.
I just wanted to say it was a very good presentation.
Thank you. Thank you, doctor.
Of course, you're welcome.
Okay, thank you so much. So we can move to the next topic. So as we know, sample size estimation is one of the essential steps in planning a strong research project, especially in questionnaire-based studies. It helps make the study more reliable, more organized, and significantly stronger. So our next topic, it will be about how to estimate research sample size used in questionnaire-based studies. Will be presented by Dr. Mohamed Ahmed. Dr. Mohamed, if you are ready.
Yes, I'm
The floor
ready.
is yours. Yeah, go ahead. You're welcome.
Hello, everyone. My name is Dr. Mohamed Abugibba. Today, I will briefly discuss sample size and estimation in questionnaire studies. As Dr. Amir said, it's an essential step in research design that directly affects the validity and reliability of the study findings. Is my presentation clear?
Actually, I can't see. Are you sharing your screen?
No, not yet. Let me.
Dr. Mohammed, your mic is muted, I think.
Yes, sorry for the delay.
No, it's okay.
Okay, my name is Dr. Mohamed Abugibba. Today I will briefly discuss the sample size. So in the beginning, why we are discussing sample size? Okay, so is my presentation clear?
Yes, very clear.
Okay, so before starting any questionnaire for a study or something or research, it's an important question to ask ourselves: how many participants should we include? I gave this example of burnout among internal medicine residents. So how many residents should we survey? So sample size determine whether the results are trustworthy or not. So if we collect data or do a sample size of too small population, it will give you unreliable results. And if it is the vice versa, if we took large sample size, it will make waste of resources. So the appropriate size should be calculated to give you a valid and precise results. So what's the determinants of sample size? It's the confidence level. It's also margin of errors, usually 5%, and confidence is 95%. And what also is expected prevalence, the population size of the study, and non-response rate of the questionnaire itself. So confidence level, what is confidence level? It reflects how certain we are that our sample size estimates represent the true population value. Like the most commonly used, it's 95%. This means if we repeated the study or questionnaire too many times, it will give you the approximate of 95% of those study would contain the true population value. And what is the margin of error? It's the maximum acceptable difference between the sample estimate and the true population value. And the most questionnaires studies usually use a 5% margin of error. For example, if burnout prevalence is estimated at 30%, a 5% margin means the true value is likely between 25 and 35. So it's a 5%. And what they expect, the prevalence refers to the proportion of individuals who have a particular characteristic or condition. And what about the population? And what about the non-response rate? Not everyone invited to participate in the questionnaire will respond. So therefore, researchers usually increase the calculated sample size by 10 to 20% to compensate for expected non-response. So you have to put it in the equation. I'm not good at formulas and calculation, but this one I will try to make it simple. So the formula of sample size before any questionnaire you want to do is equal Z square times B 1 minus B divided by D square. N is stand for the sample size itself, and the Z the confidence level. Statistic, as we said, is 95% from the previous. And the B means the expected prevalence, and D, as we discussed, it's the margin of error. Okay, so I will give you a practical example. If you want to measure or do a study about the burnout prevalence, we're gonna use, as we said, usually we use confidence level of 95% and the margin error of 5%. If the prevalence is unknown at the study area, if it is unknown, we're gonna use 50%. So when we do the calculation itself, the required sample usually of a study will be equal to 384. If you use the previous calculation, the Z square times B 1 minus B divided by 2 D square, it will give you most of the study 384. And the important point that if the prevalence unknown, we're gonna use 50%. And we discussed about the non-response adjustment. As we said, it's usually when we do questionnaires and we share it to be responded that around 10 to 20% they might not respond. So we're gonna use divided by 0.9. So we're gonna increase the sample size to 427. So we're gonna add always 10% to 20% for non-response adjustment. There is software commonly used like OpenAPI or APIinfo or 𝗥𝗲𝘀. Fortunately, it's make our life easier, so they're gonna calculate the sample size. But it's better to be sure or to know the formula itself about this sample size. So the take-home messages calculate sample size before any data collection. We are using 95% confidence, and we define it before, and 5% precision, margin of error. In most surveys, we use the 50% if the prevalence is unknown. And we're going to do the 10 to 20% for the non-response adjustment. And as I said, as there is many like software application, you calculating the sample size, but it's better to understand the concepts more than the formulas. And thank you.
Thank you so much, Dr. Amr. Dr. Mohammed, I'm sorry.
Armin, any questions?
Dr. Nader, do you want to add
Thank you so much,
point?
Dr. Mison. I think both you did great. So both topics are important and excellent presentations. Thank you.
Thank you, Dr. Nader.
Anyone have any question or want to add any point? Okay, thank you so much, Dr. Mohammed, for a very useful and practical presentation.
Thank you. Welcome.
So we will move to the next topic. It's a very important and practical topic for us as fellows, especially because the systematic review are one of the key research skills we need to develop. And a well-written systematic review requires a clear research question, a strong methodology, proper screening, accurate data extraction, and structured reporting. So our next project will be about how to write a systematic review, will be presented by Dr. Amr. So Dr. Amr, if you are ready, the floor is yours. And if you need any help, let me know.
Thank you, Dr. Malazan. Also, thank you for summarizing my whole presentation. So let me just start my screen share. And can you see my screen? Can anyone see my screen?
No.
Not yet.
Just a minute. Is it clear?
Yes.
Is my voice clear? Can everyone hear me?
Yes.
So hello everyone. I'm a new addition to this group. My name is Amir Almuiad. It's been really interesting and very excellent presentations by Dr. Mison and Dr. Mohammed. So thank you guys for that. So today I'm going to have a brief talk about systematic reviews. To be honest, this is kind of aimed at novices and newcomers like myself. So I apologize if it's lacking in depth for some of the seniors in the call. At least I hope at least it serves as a brief refresher on what you already know. So let's just start. Let's just go to slide number 1 here. So what is a systematic review? It's a term we see a lot in the research world these days. So the best way I'll put it is that it's a sort of review of many other researches. You could think of it as a research of other researches, right? And the reason we use the term systematic here is that Yeah, it's like a scientific way. There's a very structured, organized way in doing it. It's not your typical English summary, right? So how about I just start the presentation view? I think it would be better.
Go to the slideshow. Go to the
Uh,
slideshow.
Yeah, I'm looking for it.
Up.
Where is it?
It's before. Yeah, here.
Right. Yeah, so it's you can think of it as a research of researchers. I would say that's the most simple way to put it, but I guess we do need an actual definition. So you can just summarize it as 3 words. It's structured, it's transparent, and reproducible, right? So think of a traditional narrative review, like an essay or an author, where they can just choose their favorite papers to prove a point. A systematic review is not that. The opposite, actually. So it uses like a strict, predefined methodology to eliminate all that sort of bias. So we perform a comprehensive literature search across multiple databases, preferably all the main ones, to find everything that has been published on a specific topic. So that is what a systematic review is. So now, why should we do one? What is the point? Why are you investing so much time and effort into doing this? Why is everyone talking about systematic reviews? Well, there are a few reasons. Let's summarize here. So first, it summarizes the evidence we already have, right? So for a long time, an example off the top of my head is that for a long time, thrombolytics weren't first line in stroke. Like back in the 50s, there was a lot of debate on should we administer them, when should we administer them, etc., etc. Only until around the 1970s that there was a review paper summarizing all the clinical trials of the decades prior that made it clear that thrombolytics are essential in improving patient mortality and morbidity. So it summarizes all the existing evidence, right? Second, it's helpful for the knowledge gap. Like I said, you can use that same example. We didn't know if thrombolytics were increasing or decreasing, or having no effect at all on stroke patients. Third, it supports evidence-based practices. It serves as the foundational cornerstone for high-grade medical practice guidelines. It reduces assessment bias. It kind of removes the decision from the doctor's hand in a way. It gives him like a strict guideline he can follow and apply it objectively across all his patients. So yeah, and informs policy and funding. So it helps all the stakeholders and government institutions, NGOs know where to prioritize their stuff and money and resources and effort. So how do we actually do one? Well, I have written a few steps here. So step 1 is formulating the question. I would say this is the most important step because it's the basis of everything else you're going to do. So there's this acronym here, PICO. It stands for population, intervention, comparison, and outcome. So I have an example here at the bottom. Here's the question. It says, in adults with primary hypertension, does aerobic exercise compared with no exercise significantly reduce systolic blood pressure? Can you guys see the question? Yeah. So in this example, the population are the adults, right? Adults with primary hypertension. The intervention is aerobic exercise. The comparison is those who do not exercise. And what we're looking for here, the outcome is the effects on the systolic blood pressure. So as you can see in this example, it's kind of a specific question, right? Like we're only talking about adults. So that's above 18, right? And primary hypertension. So we're not talking about any other secondary cause. And we're talking about aerobic exercise. So aerobic exercise itself has a specific definition. Like, are we talking about heart rate above 100, above 120, above 130? And for how long? Is it for 10 minutes? Is it for 15 minutes? So yeah, and compared with no exercise, which is basically a sedentary lifestyle, and does it significantly reduce systolic blood pressure? Even significantly reducing systolic blood pressure isn't an objective measurement, because if the blood pressure, for example, goes down from, let's say, 125 to 120, is that significant? Well, it is statistically, but not perhaps clinically. So all of it might take weeks to actually formulate a question that you can actually make a research on. So I would say this is the most important step and not to take it lightly. So let's go to the next slide. Yeah, here. So step 2, you develop a register protocol. So what do I mean by this? So once we have our PICO question, our population intervention comparison outcome question, step 2 is we develop a register protocol. So I like to think of it as like a blueprint we lay down, right? So it has our inclusion criteria, exclusion, eligibility, how we're going to do it, who is reviewing it, etc. And why it's important is that we need to prove that the research we did was not altered. For example, let's go back to slide 1 here. Let's say this is our question, right? In adults with primary hypertension, does aerobic exercise compared with no exercise reduce the blood pressure? We need to make sure we register and like post all of our like inclusion and exclusion beforehand, so that if we don't fake a significant result, because that happens a lot nowadays. People are trying to publish their paper at all costs, and they're trying to, for example, look and find for significant outcomes even if they're not there, right? So this is you can think of this as a transparency step. So let's go to the next slide. So after we have the question, after we make sure we're transparent, we need to do a comprehensive search. Now, this is also very important. So to do this properly, we have to look at multiple databases. So as you can see here, we have 4. I'm sure you've heard of maybe at least PubMed. There's also 𝗏𝗏𝗀𝗏𝗏, Scopus, Web of Science. So PubMed, which is basically the primary medical database globally. 𝗏𝗏𝗀𝗏𝗏, you can think of this as the European version. And you have these other 2 also. Now, to perform a comprehensive literature search, we need to use something called MESH terms. Now, what does MESH stand for? It stands for medical subject heading. So what do I mean by this? For example, in our question, we're talking about adults with hypertension. But adults with hypertension can be written several ways while you're doing your search. For example, it could be high blood pressure, elevated blood pressure, increased blood pressure, etc. So the way you search for this is you use MESH terms, which are basically like a standardized way of referring to, for example, hypertension. So you can just search hypertension, and then you get all the studies for increased blood pressure, elevated blood pressure. You get all the synonyms for it, so you make sure you don't miss out any studies. Because if you do miss out a study, that's a form of selection bias, and the reviewers are going to grill you if you do that. So this step is also very important. So let's go to the next slide. So you don't just take every single study that exists, right? You have to screen, have to make sure the study is appropriate or not. And there's this famous, I would say, 2-stage screening process, which is first you screen the title and abstract, make sure it fits your PICO question, your inclusion criteria, exclusion criteria. It has to fit all of that. And step 2, or stage 2 rather, is to have a detailed analysis of the remaining articles against precise eligibility rules. For example, your precise eligibility rule might be, I will only take studies that are randomized controlled trials, for example. Or you could say, I'll only take studies conducted in the last 10 years. Or I'll only take studies conducted in North America because they have the most resources and their researches are maybe better. Yeah, sorry, those are just examples. And obviously, it's difficult to do a research like this alone. You'd preferably do in groups of other people so they can spot any biases you may have. And if you guys have any disagreement in the group, you guys can perhaps vote on it, ask a third party, ask a senior, etc. So let's go on now to data extraction flow. Now, this slide, to be honest, I don't have much experience with it, so I just summarized what I found online. So they say that you should study the metadata, you should know a lot about the author, where it was published, what year, because all of this gives you context to if that study is worth including, right? The methodology, is it randomized control trials? Are they case controls? Are they cohorts? The gold standard would be that all your studies in your systematic review would be, double-blinded, randomized controlled trials, but that's not always possible. The patient demographics, so are they adults, children, male, female, all of that is important. I'm going to go to the next slide. So the point of working in a group, one of the points is that it can help reduce bias. And I have written down some examples of bias here. So you have selection bias, which is, for example, not including some studies that don't support your narrative. So if you want to publish a paper, for example, that proves that exercise decreases blood pressure, but you find a fair study that satisfies all the inclusion criteria, but it doesn't show that it reduces blood pressure. If you don't include that study, you're committing selection bias. So that's just an example. You have performance bias where, are they all doing the same exercise, and is it for the same duration, etc. These are the other examples of bias. Data synthesis and analysis. Now, this really distinguishes the difference between systematic review and meta-analysis, right? So you can think of it like this. All meta-analyses have a systematic review, but not all systematic reviews need to have a meta-analysis. Now, so a systematic review, aka a qualitative narrative synthesis. So this is used when the data in all the studies, they're just too different. For example, if you're asking an extremely broad question, like, do multivitamins work in adults? That is a very vague question. So you might not be able to get some numbers and analyze and get a number, for example, yes, multivitamins are 3 times more likely to decrease morbidity, etc. So in a study like that, you can only write a qualitative narrative synthesis. However, if your studies are very similar, for example, testing whether or not alteplase in stroke increases or decreases morbidity, and you have all the patients' ages, the exact dose of the drug, when they took the drug, for how long, then you can do a meta-analysis and summarize it using a forest plot. And I'll show you what a forest plot is here. So this is a forest plot on aspirin, on secondary prevention of MI. So we're trying to see if aspirin works or not. So if you can see here, there's all these studies. So you see, for example, Belch 2008, you see Catalona 2007. So these are all the researchers included in this meta-analysis. And then on the right here, you see the forest plot, and you see the line in the middle, that's the line of no effect. And then you see on the left, that favors aspirin, on the right, that favors the control, and for all of these studies. And then at the bottom here, you see an average, essentially, of all of the studies above. And usually it's in a diamond shape, but here it's a square, as you can see here. And you see it favors aspirin. So this is basically a meta-analysis proving, you can say, that aspirin is favorable in secondary prevention of MI. So this is an example of a forest plot used in meta-analysis. So finally, you have to write your report so you can be able to submit it. Now, there's something called PRISMA that I'd briefly like to explain. It stands for Preferred Reporting Items for Systematic Reviews and Meta-Analysis. This helps standardize our report. It helps it be scientific. It helps ensure that we're following rules and we are, not writing something that only we would understand. It's making sure that anyone can read this easily. So some of the PRISMA guidelines include a title, background, and you should call it a systematic review so it's easily searched up. You disclose what databases you use, if you use PubMed, Embase, both. You list down all the studies screened, etc., and why included, why excluded. And find the actual PRISMA guideline is actually very long. I just wrote a few of them here. It's, I think, around 17 steps. I wrote 4 of them here. So let's go. So yeah, these are the steps from the previous slide. Like I said, there's many more, but these are just the basic general ones. So you identify, you screen, eligible, you confirm if it's eligible or not, you include it, etc. Let's talk about some challenges when you're writing a systematic review. So there's going to be an abundance of evidence. You might feel like it's endless almost. So you might find, for example, thousands, maybe tens of thousands of studies on a topic that you're trying to write a review paper on. So to help with that, you need to make your question a bit more specific. So like I said in slide, like the example you used for the PICO question earlier, does aerobic exercise decrease systolic blood pressure in adults? That's a very specific question. He's talking about aerobic exercise. He's talking about systolic blood pressure. He's talking about adults. But a poor question that would lead to an overwhelming search volume and having tens of thousands of studies would be something along the lines of, does exercise help with blood pressure? You see, that's not very specific. But when we say in adults and we say aerobic exercise and we say systolic blood pressure, that helps narrow down from thousands to maybe hundreds. And then it becomes much more manageable. Another problem is that you get data that is just saying everything. It's saying yes, it's saying no. Sometimes it increases it, sometimes it doesn't decrease it, etc. So when you're faced with that, you honestly can't do a meta-analysis anymore. You can't do that forest chart that I showed on the previous slide. You can't do a quantitative synthesis. But what you can do is the qualitative. You can do a systematic review. You can summarize the findings, but you can't really put it into numbers. So that's another problem. Also, publication bias. A lot of good studies don't get published, maybe due to lack of knowledge on how to publish, maybe due to funding problems. So you're not actually looking for all the evidence out there. You're just looking out for the evidence that's been published. So that's another challenge. So it's a key takeaway for success. You do a well-structured PICO question. You make sure that it's specific. You make sure that it's narrow so that you can easily search all the data on a certain topic. You lock down your protocol. You make sure that it's published before you finish your article, so you ensure that people can trust that what you wrote is actually accurate and you didn't just change the results to publish a favorable result. You look for all the databases. You look through PubMed, MThis. You go for all the data, not just the data you like, and you use the mesh terms we talked about earlier, so that, for example, for high blood pressure, you can see many different synonyms, but when you use the mesh term, you get all of them at the same time. So you make sure you cover all the evidence. You maintain a strict double-blind evaluation. Make sure you work in a team. You can't do all of this on your own. That will be impossible. And at the end of the day, you make sure it's reproducible, transparent, and evidence-based. The same 3 words I used at the beginning. You have to make sure it's scientific. Yeah, like I said, remember, all meta-analysis have a systematic review, but not all systematic reviews need a meta-analysis. Don't force it. If the data isn't going your way, it's fine. You can just do a systematic review. So that's the end. Thank you, everyone, for listening. If you have any questions, you can go ahead.
Thank you so much, Dr. Amr, for your presentation. It was very useful, actually, especially for our fellowship project. And understanding actually how to write a systematic review probably will help us improve the quality of our research work and make our project stronger and more publishable, inshallah. And actually also, I would like to share just a small, you can say, experience from my recent systematic review work. Actually, in systematic review, I noticed the PICO should be very clear from the beginning. So for me, PICO is not just a format we write in the protocol. It's main guide for the whole review process. So it tells us exactly who the population is, what intervention or exposure we are focusing on, as Dr. Amr said, and even so the comparison we are considering and what outcomes we are trying to measure. So I noticed when the PICO is clear, the screening became much more focused And every reviewer can go back to the same question and ask, does this study really match our population? Does it answer our review question? Are the outcome relevant? And this is literally helps the team avoid including studies that are interesting but not actually relevant. And it also helps us avoid excluding studies that may be important. So actually, I saw how important this in real projects. So in one project, following the protocol and 𝗫𝗀 carefully helped us identify studies that was highly relevant and really support the review. It showed me that a clear 𝗫𝗀 can strengthen the whole study because it guides us towards the right evidence. So to that much, literally, I was very happy about how much the results highly relevant. And at the same time, another project, I found a study that I felt needed to be re-reviewed. The decisions was not straightforward, we can say. And when I went back to the 𝗫𝗀 and protocol, I realized that it needed more discussion before making a final decision. So I believe that 𝗫𝗀 is the foundation of the systematic review. If it's clear, the screening, data extraction, results, and final results became more stronger and more advanced. But if it's not clear, the whole review can become confusing with more conflicts and weaker conclusions, we can say. So that is why I think every team members should understand the 𝗫𝗀 very well before starting screening, because it directly affects quality, reliability, and the chance of publishing of this study. Thank you so much.
Thank you for that. Thank you very much. Thank you. Thank you.
Thank you both. Thank you, Dr. Amro, for excellent presentation and concise, very important topic. So I wanted to add just a few points. Is as you mentioned, Dr. Amro, and it's a big topic and it's complex process and steps. But for the newcomers, new fellows, if you did not do research, what I suggest is, number one, get involved in one of these systematic review studies or research projects in our program. You can approach any one of the seniors in the WhatsApp group. Dr. 𝗏𝗏𝗀, for example, can direct you to join a project. So why did I say that? Because you need to start baby steps. You want to get involved in a project. You don't have to do it from A to Z. You just take one task, and this will be doable for you. You're gonna learn. Let's say I want to do the research, the searching using the mesh work, the mesh technique. So you want to focus on that. You want to know how to do that, the tools, and then do it with the staff or with the group of the fellows in that project. Or maybe you join them at the end. You want to just work on the conclusion part. So they already did all the steps. The last few steps will be like you want to conclude what the studies showed. Is it positive? Is it negative? Whatever the question was. So you work on just summarizing the findings, for example. So your task is just to review the comment or whatever summary came from the studies by the fellows in that project, for example. So you take one part, one small task, and learn about that task, and then you build on next project. Maybe you can take 2 tasks and so on, and then you can know the process from A to Z, from starting with a question till the end when you want to publish your work or submit it to, for example, a conference or as an abstract, or you want to publish it as a paper, so you complete a manuscript. So this is the point number 1. Point number 2 is that as we get out of medical school, most of us, they are filled with competition. And when you work in hospitals and so on, you want to compete, you want to make sure you are doing the right thing for your patients. And sometimes your ego is, you want to do stuff by yourself, which is a great thing. But the problem is in some of the programs here in the US or other places, they want to see your teamwork abilities by saying that if you want to be a team member and show that team membership abilities, then you will be easier to get selected for a program rather than individual skills. So yes, you are competitive. Yes, you can do it by yourself, but it's better to work with teams. Number one, you want to be a team member where you can learn from your seniors or leadership. And number two, you can progress to be a leader, and then you can teach your other members in the team about steps. Let's say Dr. Amro is new in this program. He doesn't know anything about the systematic review. He just presented the topic and he's doing excellent as far as presentation of the topic, but he doesn't know the skills. So I can ask him, can you join Dr. Mela's team in this project? They are working on hypertension, whatever. So when he become a member, then he will learn from the team the process of doing things together, and he can follow the instructions by the leader. As he develop more skills and know more about the systematic review, now he knows A to Z, all the steps. Now the presentation will be like nothing for him. He can present this topic to any of the newcomers in a few months, for example. By that time, he may be the leader for a new project. So he become a team member. Now he become, in a few months, a team leader. By that, he shows his growth as far as skills and knowledge and improvement and helping others. So he got the help at the first step, and now after a few months, he knows he has the expertise. Now he shares that knowledge, that skills and tips for the new fellows at that time. That's the part where I want to highlight in this program, and this can be applied to any part of this skills that you can learn in this program. You can learn soft skills, you can learn, let's say, presentation skills for newcomers. At the beginning, you will be like anxious. I might not be making the right decision as far as slide. Is it 15 slides enough, 25 slides? Is it too long? Am I speaking right? Technical issues, whatever. So be a team member and learn from your seniors. And then when you have all these skills, you gained all of them, then you can teach others about these tips and tricks and skills and so on. So you can apply it in a different form. The other benefit is that you can show other programs that you are able to teach. As Dr. Amro did today, he taught us about the systematic review, the steps, the tools we can use, and so on. So he can be able to explain to any programs he will apply to that. I was able to teach new fellows about this, how to run a systematic review, for example. So this, the second point, is a benefit of working in a group. The last point I want to share is the systematic review is one of the things that you can do in teams, not alone. And I'm gonna show you in a bit how is that done, because I need to confirm to you what I'm saying. So if, let's say, you are working, Melas is good at research, and she wants to show us that she can do it from A to Z, and she finished a project, a systematic review about this. She did everything to the point, but the problem will come when she submit that to a conference, for example, an abstract. It will be rejected. The reason is systematic review, you need at least two authors. It cannot be done by one. More than two is better. The more the topic is important, the more authors will be involved, and we can show this in the next slides I'm going to share with you. And the reason is one of the steps in the systematic review is avoiding bias, the selection bias. Some of the topics or studies you get involved, you need at least 2 persons to say, yes, this is matching the inclusion criteria, or no, this doesn't match. So at least 2 people. If more is better, because even these 2 people are selecting or getting the results filtered and included, they may come at one point to clash, where one will say, yeah, it's meeting the criteria, and the other person will say, no, I don't think so. So how to solve that? We need a 3rd person, as Dr. Amro mentioned in one of the slides. So this is where the confliction can be, the conflict or something like that can be solved. So this is why you need more than one fellow or one individual, one author for systematic review. If you want to write an article just in general about systematic review about any topic, you can do it alone. But when it comes to studies and so on, and you need more individual authors. Let me share with you what I'm saying to you guys. So in this, for example, I'm just looking for systematic review. I'm not talking about any topic. So this is, you can look at PubMed.
Battery.
Here, systematic review, you can see. And when you go, if you just look at every one of these are 200 pages, but these are 400,000 results. You will see how many authors in each systematic review paper. Most or all of them, except a few, are more than 2 authors. See, this is the only one I can see here in this page that has 2 authors. So most of them has more than 1 author. Just to tell you the importance of working in teams, working with other fellows, and working in this systematic review as a group is better, and you get chance to get that published as far as publication journals or get accepted for a conference, for example. The other point I want to share is, for example, this is using artificial intelligence method for systematic review in health science. This is how to select a topic, as Dr. Amro mentioned. So what you can do when you want to, let's say, come up with new ideas, you can look at an article, read it, get the concept and the findings, and see if there is a gap that identified in this. So this was done in 2022, so 4 years ago. So since then, AI developed a lot, and many tools are there. So you will have a big gap that we can study, for example, for new ideas for research projects. So you can come up with a research question. And there are different ways of modifying the research question. Let's say I want to stick with this topic. So you can do this, but you can modify. If it's done in the US, you can modify the location to do it in Europe. If it's done in the Europe, you want to do it in the Gulf area, for example. Or time-wise, you want to do it after 2022. So you will say, I'm going to repeat this research, but after 2022. So 2023, 24, 25, and 26. If that makes sense. Or the population. If this targets all the population, you want to be specific. Maybe you want to look at this in geriatric population or in teenager, something like that. So there are different ways of modifying the same thing. Last point, and this is, some people will do a systematic review of a systematic reviews, if that makes sense. So this is one example, and this is another example. So a systematic review of systematic reviews, just to give you a wide picture of what you can do. Thank you so much.
Thank you, Dr. Nadir. Thank you very much for the comments and the showing up with your screen also. Thank you very much.
Hello? Hello? Can
Hello,
anybody
Dr.
hear me?
Lujain.
Hello.
Thank you so much,
Yes.
Dr.
Hello.
Nadir.
Assalamu alaikum. I just wanted to add, like, on a point of Dr. Nadir in terms of my experience. A really good example. So I've been trying to do systematic review and meta-analysis just for practice. You can actually like do it by your own just for practice. So when you join a team, you're actually efficient. So here's an example as to why I'd like to back Dr. Nadir up on like why you need 2 people in systematic review. So I'm gonna have to share my screen for this.
Yes, go ahead.
So as Dr. Amr mentioned earlier, is that there's something called risk of bias. And so this is a spreadsheet of the Cochrane risk of bias. So this is, it's called ROB2, specifically if you want to assess like RCTs, random clinical trials, basically. So you just open this, and then here, they're going to ask you on your research, let's say like take any kind of random clinical trials, and you're going to read it. So it's based on your interpretation of what's written in front of you or the research that is in front of you. And you're going to have to respond. So this is highly subjective, right? So you're going to say, oh, what's the allocation sequence random? You're going to say either yes, probably no, or no, right? So this is highly subjective. So that's why you need 2 members at least to actually say that. And from there, you're actually going to have to compare. And simply, another thing as to why you need 2 people looking at this, like, see, as you guys can see, like, it's a hectic task. You have to type all of that. And on top of that, you have, wait, so it's going to show up like this, right? The moment that you input the data, it's going to show up like that. And so you're going to have to compare team member 1 versus the member number 2 and see what they wrote. And you're going to have either a third member, or you're going to have to discuss as to why you thought that. So it's a really important assessment of bias. So yeah, as well as in screening, it's also the same process. Funnily enough, I was talking to a researcher, and he told me that students should be more proactive when it comes to like systematic reviews as well, because like right now, journals tend to reject systematic review because of AI. And as you guys know, like Ryan has been so easy. So it would put more weight, and you guys would contribute more if you're able to add meta-analysis on it. So if ever, like, we could also like teach that here in telegeriatric in the coming meetings. So yeah, that's about it. Just a short brief experience.
Thank you so much, Dr. Lujain, for sharing your input. Thanks.
Thank you so much, Dr. Lujain. Anyone wants to add any point or want to share his experience?
I just wanted to ask just a quick question. So you 2 have both made the point that it has to be at least 2 researchers doing the review. Now, is it a case of the more the better, or is there, for example, if it's 100 authors, is that considered too much? Like, what is considered the sweet spot or the ideal number of authors? That's my question.
So I'm gonna answer this. So in general, there are, like, if you look at what people are doing, less than 10. These are the most likely number of authors for most of the systematic review. So between 2, 3, and 10. Sometimes you can see 19, you can see 30, but this usually, if there is a big important topic, like the one you mentioned, for example, heart condition, and they want to look at certain medication that is approved or something like that. So it takes a lot of expertise, and also you want to do a comprehensive assessment, and you want to put that in more or less guideline approach for policymakers and so on, or a big organization to apply that. Then you will see the topic written by a lot of authors, and most likely these are big figures, for example. In our program here, we prefer to divide the group into 10 or less authors, because in the past, when we submit posters or abstracts to one of the conference, they have slots for authors, and they have limited number of 10 or so authors numbers. So, for example, if you are working on a project, you finish it, you want to submit it to a conference. If you are 15 people working on this project, that's well and good, but the problem comes when you submit to a conference, and that conference limit the number of authors to 10. In that case, it's not going to be fair for the 5 members if you are 15 not to be included. And we come across that in the past, like the first year in this program, we submitted to a conference, and we face that challenge or that problem. So we divide the group, I think 16 or something like that, to 8 and 8, and then we divided the topic into 2 separate projects, and then next time we submit to another conference. We didn't have problem because the number of authors less than 10, if that makes sense. So I hope I answered your question. Thank you. If anyone wants to add, please go ahead.
Thank you, Dr. Nader. Very clear. Thank you.
Thank you so much, Dr. Nader.
Assalamu alaikum. This is Dr. Dalia. Thank you, Dr. Nader, for this opportunity, and thank you, fellows, for these great presentations. I just actually have one request and one inquiry. My request is that I'm still out of the WhatsApp group. If kindly Dr. Malas can add me to the group, I'll be so grateful, so I can be in touch and get more involved in these projects and presentations. And I just want to ask Dr. Nader also about the asthma project that was proposed to me in June, July, I guess. I still have not heard back about who's the team leader, how things are going to be done, and so on.
Okay, if someone can add her to the big group in the WhatsApp.
I will put my number down there, because I think maybe I tried different ways to reach out to the group, but I'm not sure what's the issue. Maybe those I contacted, they don't have the admin, or they are not admins in the group. But I can put my number down in the chat. If Dr. Malas can add me, that would be great.
So I'm adding a link to the WhatsApp group, the big group,
Yeah, that's
I think. Yeah, so if you want to join that, and then in your team, maybe you can work also. Beside that, you can also approach others if you want to work in a specific project, like we are talking about systematic review. Maybe you can join some if you are interested in. Regarding the asthma project, anyone here has any update as far as the asthma project, the mobile app?
I have update.
Yes, please.
What we make, we was so motivated, we was so happy to start the project, and we download divided two group for app COPD and asthma, right? And divided between the app phone and Chrome apps. But what happened, to be honest, because we are all new and we are all, this is first our project. That time no one had expert in systematic review and how we can do the research. So all the steps is stopped after we divided the group for the Chrome app and for app. I'm willing, if anyone like Dr. Malaz, as I know, or Dr. Omar, who talking now about systemic review, if you have any experience before, because the project need previous experience. The first time is a little bit hard for the new one like us. So if anyone willing to lead us and guide us to continue and finish the project, we will be so happy, and we can add him immediately.
Oh, Dr. Mison, sure, actually. Also, actually, you have sent me, definitely I can help you. Even so, I can help you, and why not you can lead it by yourself and tell you the steps one by one, and I can work, for example, just supervising you, and you can work as leader or co-leader, and we can continue, inshallah, and finish it.
Thank you, Dr. Lujan. Thank you so much. I'm happy for this news. Thank you so much. Okay, I will add you immediately. And we will continue when we are stopped there.
Okay, thank you.
Thank you so much.
Anyone want to add anything or have any question?
If Dr. Mison can add Dr. Dalia to the asthma group, yes, appreciate. Thank you.
Of course.
I appreciate. Thank you so much, Dr. Mison. Thank you, Dr. Nadir.
Thanks. Yeah.
Dr.
And
Nadir.
if someone can add Dr. Noon to the big group as well, that would be good. Sorry, Dr. Rupa, go ahead.
Sir, I'm unable, like I want to do some presentation. So I put up in the group, like, how do I add the TGRF on the desktop, which I'm unable to do? How do I access from the desktop or,
I shared the link. It's just researchfellowship.glideapp.io, and it should open to you in your desktop or in your phone.
All right. Thank you, Dr. Nadir. Thank you so much.
You're welcome. Thanks. As far as if you want to help with project, with presentation, Dr. Marwa will help you, or any of the fellows can direct you. Thank you. Go ahead, Dr. Melas.
Okay, thank you, all of you. So let's move forward to our next presentation. We have a very inspiring topic because many of us are interested, like not only in clinical practice and research, also teaching, mentorship, curriculum development, and academic leadership. So health professional education is an important field that helps improve the way healthcare professionals learn, teach, assess, and grow. So Dr. Nabiha will present how to become a health professional educationist. Dr. Nabiha, thank you for preparing this topic. The floor is yours. Go ahead if you are ready.
Hello, everyone. This is Nabiha. I hope everyone's doing good. Well, I have my presentation, and let me just share my slide. Just a minute, please. Okay, so can everyone see my slide?
Yes.
Okay. All right. So the topic for today is becoming a health profession educationist, and it is a very important topic because when we talk about healthcare, so there's a lot that comes with teaching and mentorship, and that makes this topic very high yield. So today we are going to be discussing a practical roadmap for physicians in training and everyone who's interested in mentorship and teaching. So when we talk about health profession educationists, we need to know what exactly is this. So any physician, nurse, pharmacist, or any healthcare professional who then builds up formal credentialized expertise into how to train young professionals and how to teach them and evaluate them. So this is a very important thing that there's a difference between a good teacher and becoming a recognized scholar and leader in science of education itself. So there are few components of health profession education that we need to know. Number one is teaching and learning. So evidence-based instruction in classroom and clinical settings, and then the curriculum design. So the educationists need to have a grip on building and reforming the training programs, assessment and evaluation, measuring the learner and program outcomes, and then the educational leadership, that is directing courses, clerkships, and programs. So at the end, it teaches us to be a leader to the younger generation. And when we talk about the health profession educationists, they're also known as either the clinician educator, medical health profession educator, or HPE scholar. So, like, another important question arises, like, why do we even need to pursue this path? So, number one, it's a recognized academic track. So, like, the person is going to have formal clinician educator promotion built upon teaching portfolios and scholarship. It is important because it'll help us shape the next generation, because we're going to influence the younger generation as to how to think, communicate, and care for the patients. It is a much publishable and fundable domain, so it is not just a service obligation anymore. It's a scholarly pursuit, and it is going to enable us as clinicians to have curriculum innovation, assessment studies, and grants. And then, most importantly, mentorship and community. So, as more people are going to join, a larger global network of educators would come across and they would sit together, and better innovations would be there. And most importantly, as we talk about soft skills all the time, so the skills that we're going to have um, uh, through these courses, they are going to be with us in whatever settings we are. And as they say, from bedside teacher to the educational scholar. So we are going to be able to mentor and teach people in whichever specialty we go to, and we'll able to make a difference. Now there are three pillars of HPE expertise. Number one is education, and then the leadership, and then the research. So we'll start with the education. So, and when we talk about education, it's about learning theory and instructional design, curricular development, assessment and evaluation methods, and then the leadership. So now we're going to direct the programs and the courses, change the management, mentoring the faculty, mentoring the younger generation, and then the research, that is the educational scholarship and program evaluation, grant funded inquiry and dissemination, like we talk about journals, conferences. So through these HPE, we can have a much grip on these. So if someone wants to pursue this pathway, how should he or she do? So we'll start with being an educator. So clinician educators start teaching, your juniors. I think that is the first step, and everything starts with that. And then there are certificates that are offered by different universities that offer programs. It's about 6 to 12 month programs. And then there are master's degrees of about 2 years. They're often hybrid and part-time as well for people who are doing jobs or don't have a full day off to pursue their degree. And then there is even much more specialized degree than PhDs for the HPE. So the programs are designed to stack credits from a certificate often towards the master degree. So this is a pathway from start to the end. Build your foundation as a clinician educator. No application required. Start now at whatever point you are. Even if it's a residency or fellowship, that's even a better chance because they're juniors. You can always teach and mentor. Teach early and often. Precept students, run small group sessions, give a noon lecture, seek structured feedback. That is a very important thing. Request peer observation and review learners' evaluations. Find a faculty mentor. So, a mentor in a healthcare is one of the most important thing. So, look for a mentor active in medical education at your institution. Join an educator development program. Many institutions offer in-house teaching scholars program. Start one small scholarship project, for example, any curriculum innovation or case-based teaching module. And at the end, why does this matter? Because every certificate and master's program looks for demonstrating teaching excellence. So the earlier you start documenting it, the stronger is your application. So now these are the few certificate programs that you can opt for. Most of them are foundational, often online and low risk. So the Harvard Macy Institute, it offers an online program, application-based blended program, either in person or virtual, built around teaching and learning, curriculum, assessment, leadership, research, and technology. Then we have another foundational course by Uniform Services University. It's an online course with 16 to 13 credits, and again, eligibility generally limited to federal and uniform learners. And then we have an HPE certificate offered by Rocky Mountain University. So we can also opt for this one. Use a certificate to test fit and build credit towards a master's before committing to a full degree. So it's a very good way of understanding your interest. And if you are very interested and you want to pursue further, you can go for the master's program or the PhD. Sorry, this second one. Okay. I'm sorry for this line. I don't know how did that happen. Anyways. Master's degree program built for forward clinicians, part-time, hybrid, and credit bearing. So there are different programs that offer the master's program. So there's Northwestern Finberg, which offers masters. Then there is again USU, University of Illinois Chicago, and then there are other tracks which offer the masters and even MPH. So the length really varies from 2 years to some of them are part-time friendly and some of them are program specific, depending upon which program you want to opt for. This is PhDs or much specialized degrees that can be offered in HPE. So if you look at USU PhD, so it builds on MHPE, add coursework and additional publication requirements. For HP leadership and research careers, then Michigan held online MS. Again, it pairs education with data and implementation science. A strong fit for your interest leans towards AI. So, as we all know, AI has become a very integral part in all of our curriculum. So, it helps us understand how to incorporate AI effectively, and then analytics driven education and systems research, and then John Hopkins AI in healthcare. It's a 10-week online program, a practical no code certificate in applying AI to clinical and operational problems, a fast complementary add on for educators teaching in an AI driven area. This is very important. Pick a track that matches your scholarly niche, geriatrics, education, or learning health systems, or any other niche that you have. So, like when you go for the admissions, there are few things that the admission committee is looking for, and we need to know that. The first and the most prior thing is to have a health degree and license. So either an MD, RN, PharmD, or any other health credential with an active license to practice. A personal statement, no matter where we go, a why is always a very important statement to give, to understand that why are we really interested in the program, and to understand our career goals. GRE is sometimes required, not always, but sometimes we do need to give GRE and submit the scores for the admissions. An updated CV, which highlights our teaching experience, our mentorship experience, leadership roles, letter of recommendations are very important, and then program specific application. If anyone wants to train in the health professions education, it's important to build the portfolio as we talked before. So, how do we do that while we are in our training, maybe, or pursuing our training? So, the first and the most important thing would be teach and collect the evaluations, percepting small group sessions and lectures, as we've talked before, lead a curriculum or assessment project, disseminate your work, formalize mentor relationship, ask medical education mentor to meet with you regularly or discuss your plans with the mentor, and give subsequent updates so that you know where you stand and how much work you still need to do. And then engage with a community of practice education interest groups, grand rounds, and national societies. Keep a living document, that is very important, that track every teaching session, evaluation, mentee, and a project as you go. By application time, your CV writes itself. Putting it all together, so from this time to in the near future, so we start with teaching and finding a mentor, and then if we really want to understand our interest, we can have some certifications. There are different universities offering programs of about 6 to 12 months. We can go for those certifications, and then we can also go for the master's program. Some of them are full-time, some are part-time, of about 2 years, and then we can even go for much specialized degrees and the PhDs, which also incorporate understanding AI in the healthcare. Most programs are built for working clinicians, part-time, stackable, and credit bearing at every step. So most of them are very, I would say, accommodating for the clinicians, because as clinicians, there are a lot of stuff that is going on the side. So part-time just makes it easy to get the healthcare professions education for the clinicians. These are the resources that I used for the presentations, and these are few of the universities that often the programs for the HPE. There are also links to these programs available on the TGRF website. So we can also go there and verify the specifics that each program needs and we can also apply. I think that is it. Thank you so much.
Thank you so much, Dr. Nabiha, for your very useful presentation.
Thank you so much.
Thank you, Dr.
Anyone have
Nabiha,
any
for a great
questions?
presentation.
Thank you so
Okay,
much, Dr. Nader.
Melas, go ahead.
Thank you so much, Dr. Nabiha. Actually, your talk gave us a clear understanding and how this field is much broader than simply teaching. It includes like the leadership, curriculum development, assessment, mentorship, and research in medical education. And I also really liked how this topic connects strongly with career development and future applications. So, as you know, in many competitive applications, whether for residency, fellowship, scholarships, academic programs, or leadership opportunities, committees usually look for applicants who are not only clinically strong, but also able to teach, communicate, lead, mentor, and contribute to the learning environment. So this is why education experience is very important in any application. So it shows that the applicant is not only gaining knowledge, but also able to organize knowledge, share it with others, support learners, and contribute to academic development. And it reflects communication skills, leadership, teamwork, confidence, and commitment to continuous learning. So I think your presentation was very relevant for all of us, especially as fellows who are trying to build a stronger academic and professional profile. Thank you again, Dr. Nabiha, for opening our eyes to this important pathway and for showing us how health professional education can become a meaningful part of our future career. Appreciate.
Thank you so much, Dr. Malas. This presentation itself was so eye-opener for me as well, because as I was, preparing for it, I realized how important teaching and mentorship and understanding the needs of our juniors and being there for them actually is for us as clinicians, as physicians.
Thank you so much.
Thank you so much, Dr. Nabiha. Yeah. And I'd like to share with you one experience. One of the fellows in our first batch, he was applying to a program that he is very interested in, but he did the interview and they did not accept him. And he applied the next year. But in this year difference between the first interview and second interview, he was able to improve. When we worked together in this program, he was able to participate in different activities. We were a small group, so he was teaching. He worked in different projects, research projects, learning different skills, as you mentioned. And by the time he had his second interview, they accepted him in the program that he was interested in. So one of the things that I heard recently during the interview season, you prepare, and one of the things that you may mention in one of your answers is stating that I was strategic during my last year. I did whatever list of things that you did. I learned whatever things that you learned. I thought I was involved in teams, I was involved in whatever. So by saying that you are improving during last year, you are doing this and you are learning this, you are teaching this, you acquired this, and you are successful in this, you will show them that you are a trustworthy person who not only will be added to their number of trainees, but also will be able to improve the program or contribute to the program, or as in this case, you can teach medical students and others under you as you go along. But thank you so much for sharing this topic, Dr. Nabiha.
Yeah.
Actually, just I want to add more points. Like even so, within the residency, they are focusing on like developing the educational skills and so on, and to be educationist, or you can say to be like sharing knowledge. Beside even so, like building your clinical skills or building your clinical identity, we can say during the residency years. Because here, even so, for example, we are if you are duty and so on, and beside even so you are caring and so on, and you do your job responsibilities. If you are resident, you can say it's something mandatory for you tomorrow morning, where you will gonna hand over in the morning meeting. You should present topic related to for example, any patient actually you made, or you can say you provide management or care for them during your duty. For example, like the last night. So tomorrow morning you will gonna present and discuss, for example, any new what you learn. You can say you have to go and study, for example, the topic and so on, and then you will gonna share it with your colleagues, the other residents, or even so the consultants and the specialists and so on. So actually sharing knowledge, it was something very important, and we have literally to opening our eyes. We should improve our skills as educationists, literally.
Thank you so much, Dr. Melas, for sharing this. And any other comments, topics, questions, or addition, please feel free. If not, we can go on to the... Go ahead, Dr. Mohammed Makkawi.
I was just going to say that I have my presentation here after this. Yeah.
Oh, I'm sorry. Go ahead.
You just let me share. Yeah, I'm ready. Just let me share my screen.
Yes.
Okay. So I'll be giving a brief talk. I'll be talking about tips for starting residency, since now is the residency season is going to start. The new batch is going to start next month on July. So having some tips will help you a lot before starting. So some of you may be either a fresh graduate or maybe already have some work experience before starting the residency. So for those especially who are just fresh graduates, so for them the transition from medical school to resident, it can be daunting. When you're a medical school student, even when you were doing hospital rotations, not much was expected from you in terms of work. So you were like, you could be passive and you won't face any issues. But now you're an active part of the team as a resident, so a lot will be expected from you, and so it can be overwhelming. And AMA highlights some disconnects between their skills, the new resident skills, and residency pace. So usually what happens is that during even the clinical rotation during medical school, the students will develop a good amount of skills. But the thing is, the pace in which when you are starting as a residency will be different. So you may feel overwhelmed, you may feel backed up, you may struggle. So I'm here to give you some few tips before you start your first day in the residency. So history and physical examination. No matter what specialty you go, even those of surgical specialties, history and physical examination is always considered the bread and butter of medicine. So it's the most important skill that even more than 94% of program directors expect that the new resident should be completely should be very well in doing it. And it's very important to be able to do a comprehensive physical history and physical exam without any hand-holding. So you should be able to independently conduct a comprehensive history and the clinical examination depending on the case that you're facing. And this is the area where a lot of program directors actually report a huge gap. So it's really important to hone on your history examination and practice it a lot. And hopefully within maybe a month or so in the program, you would be very good in it and you shouldn't have any issues. But it's better that before joining the program, you should have some, you should be very good in it. Then we have the art of handoff. So you should know that we know in medicine, it's not just the doctor does stuff. Maybe in Sudan it was like that the doctor does a lot of things by himself, but everywhere else it's a team sport, and you have various levels of doctors. You have your residents, your fellows, your consultants, senior consultants. You have nurses, PDs, lab technicians. So you have a lot of colleagues who are with you. So it's important that you should be able to have great communication skills with them. One of the things is one of the most important components of this communication skills is to hand off a patient. So for example, you're starting a resident. So most likely, let's say that your work is from 9 to 5. So from 5, you hand over your patient to the floater or the on-call resident who will be working during the night. So it's very important that you should be able to condense the long history of the patient that you have taken from him in a brief 2-3 sentences, so that the one who comes after you will be able to know what exactly is wrong with the patient and what is expected from him to do, so that he can better take care of the patient during the night time. And it's also program directors, they prefer those candidates who know how to cut to the chase. So with 2 to 3 lines, they're able to understand all the important crucial points regarding the patient. Okay. Then the paperwork trail. This is basically your documentation. So we have a saying: anything not documented means it's not done. So if you didn't document any discussion, any procedure, if it's not documented, it means that legally it's as if it's not done at all. So it's really important that you should document these things. Furthermore, it's not just documenting everything. It's important also important skill is to document accurately and efficiently. So it should not appear like a data dump where it's just a long history, but one who reads the note after you will not be able to figure out what exactly is wrong with the patient. Okay, then we have integration. So like I said, the change from medical school as a medical student to resident is a big change. So your ability to accommodate to this change can give you an edge over the other candidates when you start working. And it's when you're studying as a resident, you're no longer an observer, but actually a gear in a large machine that we call the hospital. So you're no longer passive like when you were in the medical school. And here you'll be working as part of a team. Like I said, in medicine, it's never you. It's always the team. And the team consists of, like I said, not just other doctors. You have nurses, you have pharmacists, you have lab technicians. You have a variety of teams. So it's important that you should be able to integrate yourself to know about the system of the hospital. And also finally, the patient outcomes not just depends on the patient depends on the entire ecosystem, which we have just mentioned right now, and not just the physician's orders. So these are my 5 main tips that I would like to give. There is a bonus tip that I would like to give: triage. So one of the skills that is important is that you should be able to assess a patient once you receive him, especially those who are working in the emergency department. So they should have situational awareness about the patient's condition that is, and be able to give an initial assessment on the patient and do the first steps of evaluation. And then if the patient needs or the case requires assistance, you should be able to call for help, and you should be able to at least try to manage the patient until that help comes. So this applies mainly to emergency physicians, but it can be applied to any department because at any time, any of your inpatients could develop an emergency. Then there is a bonus hint that I would like to give: time management. So when you were in medical school, you didn't have any time constraints because again, not much was expected as a medical student. But as a resident, you're a full-fledged doctor. So you'll have a lot of cases and you'll have to juggle between each of these cases, prioritize which ones are more critical compared to others. So these are actually big hurdles for a new resident. And this sometimes you may have faced some failure due to your work. This happens when there is poor work organizations, when you're trying to prioritize tasks, especially when you have a full patient load. And final tips, you should be able to move beyond textbooks. You may know about all the diseases in the books while you're studying for the USMLE, but that alone is not enough. It's important that you focus on efficiency and how to prioritize your cases based on urgency. And communication is really important, not just with the patient, but with your other colleagues as well. And you can also get more tips from your seniors. They're very helpful. Most of the programs are very helpful and they give you valuable tips. So be sure to have an open ear to get whatever you can get from your fellow residents and improve yourself over the course of the years. So I hope that you benefited from this presentation. If you have any questions, I'm ready to answer. Thank you very much.
Thank you, Dr. Mohammed. I wish next presentation tips for all the grad with gap, how they get match.
Matching, because I myself, I'm not matched, so maybe other fellows who are matched, they will have more better experience in that regards. But it can be prepared. I can work on it next time.
Thank you so much, Dr. Mohammed, and thank you for willing to address the topic suggested by Dr. Mison. Thank you.
Yeah, hi, Dr. Nader, Assalamu alaikum. First, appreciated you. I'm honored really. Be here with a great team here. I'm Jamal Ahmed from Sudan. Really appreciate you, Dr. Nader, for this effort, and Dr. Makkawi, and everyone senior here. I'm really junior here. First time will be with you here, and really I'm so happy. Just I want to ask something here with about Dr. Mohammed Makkawi. He's said about a lot of sin. Really, that is good, and how to self-improve yourself before starting medical residency. Exactly, and I said that is very stressful here, and how building your building resiliences and efficiency and balance for your demanding year ahead. That is good, really. And I want to add something here. I saw that in my step 2 preparation, a lot of residency being burnt out after finish his, during his year, first year exactly, because that is not take good sleep or recovery, and how to be manage that priority, sleeping and recovery, and building exercise in your routine, like walking or bodyweight exercise or gym session, and about eating very well, or how to make a meal preparation, because that is take long time during residency. Exactly, maybe some people I know, some friends, it take about 18 hours per day, and that is hard for them, and hard for us, inshallah, in future when we are make matching, and how to address that your health and emotional support. Exactly, if you have friend or co-residents or family, they support you very well. That. And thank you, thank you so much, and appreciate it you, Dr. Nadir, my son, and Malaz. And inshallah, we see you next project or next meeting. We have something, or I'm share about everything I have, about my experience in intermediate. Exactly. Inshallah, in future. Thank you so much.
Inshallah. Thank you so much for adding all these comments, Dr. Jamal. Thank you, and welcome to the program. Any other comments? If not, we can move on to the updates. Any updates? We have a couple of conferences coming soon. The Alzheimer Association in England, we have at least 2 posters we're supposed to present there. So Dr. Asma and her team, I think, I don't see her here. Asma, yes. Please go ahead if you want to share, update us. I know there are 2 posters, and Dr. Noor or Noura, she's not here, but she, I think, planned to attend the meeting as well. So Dr. Asma, if you are here, please go ahead, share your input. Or you can jump in later. And the other conference, we have also 2 abstracts that will be presented or posters in Michigan in August. So I think Dr. Noon and Dr. Lujain, if you have any updates, tell us if you have questions. Regarding the poster printing and presentation, we need to get the dimension. Usually it's 3 feet by 3 or 4 feet, but the more specific, maybe we can work on that. Go ahead if you have any input.
So as far as now, we're still on the poster making stage. And yeah, we were told it was meant to be 42 times 32 centimeters, like the height and width. And other than that, I will be sending it to you for like final approval once we get to finish it. Yeah, thank you.
Sure. And I think here at MSU, I think they have some printing service, so I will try to figure out if we can print it here and see who Dr. Noon, how to communicate with giving you the abstract, the poster. I'll plan to attend that meeting as well. So thank you. So you are working on one poster, Dr. Lujain?
Sorry, I didn't catch you.
You are working on only one poster?
Yes,
designing...
only one. Yeah.
Do you know
the one for Dr. Ala, still haven't I texted her about it, and she said when she gets to the final polishing of it as well, she will send it to me. Yeah.
Okay, so I just want to get involved. If you can, let her know so that we can work together. Thank you. And Dr. Noon?
Yes, Assalamu alaikum. I'm really so glad to work with Dr. Loujain in their project, and it's really a good opportunity for me to represent this project in the MSU conference. And I'm ready for any help regarding the poster and everything. So just let me know and updating, and yes, I will be ready for anything, inshallah.
Sounds good. And as Dr. Mela has mentioned in past few conference or meetings, she presented in one of the conference. So one of the things you can do, Dr. Noon, is to go over the abstract itself and try to or work with Dr. Loujain or any one of the members in the team so that you can practice presenting the topic, the content, and familiar, and answer questions. Let's say just make any questions Dr. Loujain ask you, and then you can practice answering these questions, because in the conference, when you have the poster behind you, people will come, but also some judge will come and ask you this question like, why did you choose this, or what happened this, or what's the next step, or what's the future, something like that. So if you practice this will be great. Sometimes you may get questions where you don't have clue or answers ready, so can at that point you can just ask them for contact information, and then you will follow up with them with some answers, if that makes sense.
Yes, sounds good. Yes, thank you, Dr. Nader, for your advices.
Thank you.
Dr. Noon, try to also make connections, the most important part.
Excuse me?
Yeah. I said just try to make connections. Really good thing for the conference.
So when you go to the conference, make connection.
Yes, exactly. Yeah, that's what I'm looking for, inshallah.
And take a lot of pictures. Okay, thank
you.
you.
Inshallah. Thank you so much.
Any other ideas, updates, questions, or new projects?
I believe, Dr. Nader, that one of our presenters for the other team, the one for Alzheimer's, is here, Dr. Asma.
Yes, I was waiting for her, but she didn't answer. Dr. Asma, I see her name here. You are muted if you... Oh, now we have you. Go ahead.
Hello, Dr. Nader. Yeah, just it is wise praying time for Maghrib, so I must answer. Hello, everyone. Hello. Yeah. So.
Hello. Yes.
Yeah. Just a minute.
She is in London. The difference in time, and she has a kid. Go ahead, Dr. Asma. Yes.
Yes, yeah. Hello, everyone. And today I will present our project, Care Response. It is a digital platform for non-pharmacological support and behavioral analysis in memory care center. Just a minute to share the screen. So, does the poster now appear for everyone? Hello. Yeah, my screen is now appear or not?
It's not here yet. No.
Oh, okay. Just a minute. And now?
Yes.
I think, yes.
Yes.
Okay. So, just move forward. Sorry everyone for this inconvenience, but
that's all right. Take your time.
okay. This is the care response app. Background. So the behavioral and psychological symptoms of dementia is prevalent among residents in memory care centers. So the non-pharmacological support is gold standard for managing these behaviors. However, the caregivers and the staff members lack a real-time tool that help them translate this observation into practical care strategies. So to address this gap, we designed the care response, and it is a digital platform that's designed to help the caregivers working in memory care centers. The goal to generate a rapid standardized care response and person-centered guidance. So the care response uses a hybrid architecture combining searchable database of more than 60 validated dementia related behaviors, and also it is use constrained AI protocol that generate standardized response. So when a staff member enter a behavioral scenario, the app generate response in form of a crisis card. So this crisis card is structured around 3 domains. First, redirection with actionable simple tasks to calm the residents, and with environmental adjustment like adjusting light or noise, and also with verbal assurance of the residents, which is revalidation. The preliminary test of this app that it is demonstrate that this app able to generate rapid response in under 3 seconds, and also there's accessibility features like adjustable font size and high contrast theme, and also it is usable on the mobile phone, and this app doesn't require any sign in. Just you can upload the app, and then you can go and select a scenario or select scenarios or enter the description of the behaviors that you are encountered. And the future direction of this app, it is to focus on broader usability testing and implementation with memory care settings. So I hope this is clear.
Thank you so much, Dr. Asma, for also great presentation. So the topic is highlighted, and
thank you
I think
everyone. Thank you, Dr. Nader.
Thank you. You did great. Any questions? Any comments? Any tips that you want to share with Asma? Go ahead.
Dr. Nader, I just wanted to ask a question. Am I allowed to put like an almost like am I allowed to change our title to something more fun? Because I thought it's not like, I don't know, I feel like the title was too boring. It's like, oh, cross-sectional analysis of fibromyalgia, like to put something a bit more eye-catching or something that would catch someone's curiosity, or is this allowed?
I don't think it's allowed.
Okay.
But in your presentation, if let's say you are not presenter, but if you are, or Dr. Noon in this case, then you can modify the title the way you want to attract the comers when you present. Let's say the judge or the people come to you and talking about the AI, and then you can modify just the whatever catchy title.
All right.
So yeah.
Thank you so much, Dr. Nader.
You're welcome. Any feedback to Dr. Asma?
Yes, please. I appreciate any feedback regarding my way of presentation or anything. So if anyone had feedback, please.
Just don't be nervous, Victoria. Good luck.
Yeah. So to the nervousness or the anxiety, I think, first of all, I want you to know, I think you went through the topic, but I want you to understand the app, use it maybe with your family member, friend, or wherever you can access in this group maybe. And the second part is most of the people who come to the conference will not know as much as you know about the app, first of all. So you will be talking to people with no knowledge at all. So don't be nervous because they're basically kids in class, like first, second class, and you are university graduate. So you are PhD in your topic. So don't be anxious. The third thing is you have a demo. I'm gonna add the QR code, so you can ask them to scan the code, and they can do that on their phone, tablet, whatever, and they can see what exactly the app will do in a timely fashion, so they can look at it and see it. It's basically as if you are in a mall or a shop, you want to sell someone something, so they can touch, feel, and then they decide, yeah, I like it. But basically, you are telling them what the topic about, what the problem about, and how to solve the problem, and what we did. So as a team, we developed this app. As a team, we used the tools available. One of them is the AI to generate some guidance or tips. And we have a database already made so that we have access to most of the common scenarios. So this is what you want to share with them. And the caregiver or family member who is involved with patient with dementia, we want them to have something on their tips if they need to in this situation where they know the patient is aggressive or they want to calm them down, what they can say, what they can do, what they can use to help them calm down, for example. So it's just try to teach the public who come to the conference about what you want to do. The topic itself, the title is big because it goes along the guidelines of the CMS and the US and the whatever. This, I don't think anyone in the conference will come across asking you about the big topic or who's CMS or guidelines. What they want to, most of the time, either they have family members who has Alzheimer or they work in a facility where they treat patients with Alzheimer's. They want you to show them how to fix a problem they face on a daily basis, if that makes sense.
Yeah. Thank you, sir. Dr. Nader. Thank you so much.
I noticed something. This is a question on like genuine, because I don't know the rules or like out of ignorance. I noticed on top, you guys had used Claude. Are we allowed to actually do that in the conference? Like, is this allowed in, or are there certain rules as to whether using a AI when it comes to poster presentations? Just so we could also have an idea on behalf of my team as well.
So it's a nice question because the conferences, they don't care how you design your poster. They want it in a PDF format or sometimes PDF and video format if it's virtual, or if it's in person, they want you to, in this case, they want you to give them a PDF format just for their records electronically. And when you go to the conference, like in Michigan, you want to bring the printed format of the poster. But the design of the poster, you can use PowerPoint, you can use Google Slides. In the past, people used Photoshop. Any software that can design the poster for you, you can use. And now with AI, you can use Canva. In this case, you can use other AI tools that generate Replete is one of them. So any tool, there is no limit as far as how you design your poster, if that makes sense.
Amazing. Thank you so much, because like it's genuinely something I thought about, because I had told my members to make a presentation, a PowerPoint presentation, or either Canva, but they had said that they mentioned that it was a bit hard. So I asked one of my members, and so like putting that into like as our option, now it's a bigger world for us. Now we can design through either whatever. As well as I noticed as well with the text, because they gave us like a particular width and height. I was wondering the size of the text itself, because then again, coming from an ignorant like background, what size is required? Like 20, 24? So I'm not entirely sure.
So basically, you want to, if it's a printed, they want you to make sure people will be of a distance of, let's say, 3 to 4 feet. They can read the whole text, not only the title, big title, but only the text in the boxes, like the method or the table what inside. So it's a readable font when it's printed. As far as if it's a PDF and virtual, I don't think there would be a problem, because people on using the computer or the tablet, you can increase view. So even if it's very small, tiny font, you can increase that in size. But for printing the poster, you can go by their, most of the time they say the smallest will be like 18 or 20, something like that. So you can go 22, 24, something. And it depends on how much text in this size of poster you want to add. If it's a lot of text, then the font will be small. If you condense the text to small bullet point, your text might be bigger. And most of the time, we want you to create table or graphs so that you can summarize or minimize your text. People don't like to read the text a lot when they can have an image or a photo, or for example, in Asma's presentation, when she says you can use your phone to scan this and see this in actual on your phone, that makes a lot of sense instead of reading the whole text for them.
Thank you so much, Dr. Nader. Very informative. Thank you.
Any other questions, updates, anything that we need to discuss before we adjourn?
Oh, Dr. Nader, so in the future, I'm going to try to make a systematic review and meta-analysis, hopefully with the members. But I would like to ask if anyone here has like an access for Turnitin, because right now it seems like a problem for like journals. Turnitin is honestly a pain in the backside. So yeah. If anyone knows how I could get access to Turnitin, but illa the paid, because I can't really afford that. It's actually expensive.
Anyone wants to share the answer? You can put it in a big WhatsApp group and see if there are any fellows who work with this. Sometimes universities might have access to these tools, and you can add one of the fellows who goes to one of these universities, for example, and then they can help with using the tool.
Do you have any idea, Dr. Nader, if Sudanese institutions like provide these kind of things?
I have no idea, unfortunately, but sometimes you may access and contact the institutions like UFK, for example, or sometimes these apps or these tools, they have some low cost or free accessibility to people in conflict area or in third world. Like if the author from Sudan, for example, they may give you an access for something.
Okay. I know that Cochrane
Mm-hmm.
gives to low-income countries. So if you guys would want to try that and access that, they have like a lifetime membership for those living in Sudan, and like it's an open course for anyone who would like to have an in-depth explanation for systematic review, and it's really helpful. I started with that, and yeah.
Yeah, and actually one of the fellows in this program who was in Saudi Arabia, she matched and she worked with Cochrane. So not only taking their courses as online classes, but she was involved with them and she became, I think, a reviewer or some sort within the group inside the team of Cochrane itself. So think about it as not only you are a receiver, like you want to learn, you want to go take the classes online and certificate and so on to put it on your CV. That's one level, but think about another level where you can be a part of the organization, how to become a team member in that organization, how to become a volunteer and extended hand to them so that you can not only benefit from them, but also benefit them, contribute to their goal or whatever. So some of these big tool companies, they need some people to be in their teams. So thank you.
Thank you so much, as always, Dr. Nader. Thank you.
Yeah, you're welcome. So I'd like to thank you all for attending this meeting. Thank you all the presenters, and thank you, Dr. Melas, for moderating this meeting. And I'd like also to thank those who will watch the recording in the future. Have a wonderful day. We'll see you next week. If you have questions, please contact me. Send a text, email, or call or WhatsApp. We'll be happy to help you. Assalamu alaikum. See you next week. Inshallah. Fi amanillah.
Thank you so much, Dr. Nader.
Thank you, Dr. Melas. And I wish you all. Yeah, go ahead. I'm going to stop the recording. And then
let me just